Thank you for invitation to Ella. Thank you, Martin, for such a nice introduction. I hope the presentation will come up. I owe Martin a lot. Yes, for example, this. Fellow of the Royal College of Surgeons, you need 2 surgeons who say this man is good enough to be surgeon working in United Kingdom. And Martin, yeah, thanks. Martin was one of them who actually supported me in getting the licensure to work in Great Britain. This lecture or this theme which I will describe, I call it, I took the name from the heart transplantation program, where when the heart fails, you try to replace the function of the heart, and you can use artificial heart. And you can use it in different ways. You can use the artificial heart as a destination therapy, which means that that's the last resort for the patient. You can use it like a bridge to some more decisions, to something which comes afterwards. Or you can even hope that with the artificial heart, the patient will recover. And if we look on the biodegradable stents and on the indications of them, we can see almost the same names, or we can name it that way. It all started, first work published about the biodegradable stents in clinical settings was done by Dr. Novotny on a rabbit model, where 30 stents were implanted in 30 animals. And next one. You see the golden markers. This is a rabbit. There is trachea. Next one. And these groups of rabbits were then abducted or were sacrificed after 3 weeks, 4, 5, 10, 15 weeks and investigated. Next one, please. This was the origin, or the upper part, the medium or the distal part of the stent, and after 15 weeks you can see these stents disappear. Next one. These are the specimens. After 3 weeks, we can still see the stent. 4 weeks, 5 weeks, it's a disappearing stent. After 15 weeks, there was no more stent inside. This was the histopathological investigation. Next one. And please have a look on this table. This says what happens when the stent is implanted, what happens clinically with the patient. In this case, this was a rabbit. So on the beginning, with the week 3, this is so-called tracheal damage score, and it shows the reaction of the trachea on the stent. And the maximum of the reaction, so when the patient or the rabbits were really sick, they couldn't breathe, it was around the week 5. So between week 5 and week 10. And this is something which not always is seen as an issue, but the thing is, if we implant biodegradable stent, we implanted something which interacts with the organism. So it is not that we just put it there and see you are safe. No, the patient needs to be followed up closely, especially with this in mind, that after week 3, 4, 5, when they are fine, something starts to happen. Next one. So the next work, which was from Prague, from Motol, it was the adult work from Dr. Lischke, where, next one, where they implanted in 6 patients, 20 stents in patients after lung transplantation, when there was a stenosis on the bronchial anastomosis. Next one. Next one. It worked well. Some of these patients needed more stents. Next one, please. Next one. But all these patients, except of this one who left the Motol hospital and let herself be treated in a private practice. So all these patients are still doing well. Next one. And this was the work from London. Next one, where in the group of patients which are treated in Great Ormond Street Hospital, which is only hospital for children, which takes care of children with cardiothoracic and tracheal diseases. So in that time they had about 500 patients with tracheal diseases. 57 of them needed already metallic stents. Next one, please. And the metallic stents, they have complications, like in this patient who died through the protrusion of the stent into the vessel. Next one. And the most important in pediatrics, in children, the metallic stents, they do not grow. Next one. So the work presented was with 11 stents in 4 patients. And they all did in the first follow-up really well. And just to mention the one with the next one, the one with tracheal transplantation. So you can see here how it was actually, which was one of the most difficult things, was to find the proper size of the stent for the proper size of the trachea. Because before you know the size of the trachea of the donor, you can't have the stent, because we had to order the stent. So this was the intraoperative fixation of the stent inside of the trachea, and it was the immediate result. And then when the stent dissolved, as Martin showed us, that this patient is doing really well. Next one. I hope if we would have sound, we would hear that this patient did really well. At the beginning, he went to TV, and he could show, as you see, 9 months after transplantation, that he can play drums with a big band in Irish TV. So, next one. Oh yeah, now yes. So, it was excitement. I was excited, colleagues were excited. It is so great that it works so well. And if you publish something and you are excited and you are impatient, then it can happen that you get such an email from Dr. Ektesali. I write regarding the recent publication. Specifically, we have 8-month-old baby with complicated pulmonary hypertension after bilateral lung transplantation. So one of the indications which are already used in Motol, with bilateral bronchial narrowing, was responded to dilations. Was wondering we could get access to these stents and help this baby. So very emotional letter. Next one. Almost in the same time, another letter from a mother who writes, "I'm a mother of 6-month-old girl. She is born with very serious heart defect." Next one, please. Truncus arteriosus, interaortic arch. Till the surgery, she had to be ventilated with CPAP. So she was born, and from the delivery room, she was connected to the ventilator. So since she was born, she spent all her life connected to the ventilator. Doctors are with no advice how to save this problem. And so please help how to proceed. Next one. And almost at the same time, another mother who can read PubMed, who can read internet, and she writes, this is in German, but she writes almost the same. I have a boy, he's 15 months, I have 15 months old, it's 15 months, and since he is 6, he is connected with the ventilator. Please, doctor, you did this biodegradable stents, help. So excitement, let's do it. And then, next picture. And then, 8 months later, 8 months later, Dr. Vondrys, I'm sorry to inform you that patient expired. It's the American patient who was waiting for the biodegradable stent in America. Next one. This is the European patient number 1. Dr. Vondrys, the patient, my child died. 8 months after first contact. Patient is dead. Next one. And the patient 2, dear colleagues, I regret to inform you that we have lost the patient on October 26th. Interesting, this patient was born 26th of October 2011 and he died on his birthday 2 years afterwards. So, should we just stop it and get upset that it doesn't work? What's wrong? What's the problem? Or why should we do it at all? So, next one. This is the timeline. This is the contact where the patients contacted me, and this is when they expired. Next one. We were able to make the first steps. We were able to make a big step, because for the patient in United States, we had a FDA approval to use this stent on American soil to treat just this one patient. Next one. So it was here, like 3 months after I was contacted. Next one. And we had even approval of the board of the hospital who suggested and supported us. And he writes, I salute this heroic effort of behalf of patient and hope for good outcome. Unfortunately, the organizational burden, the all work from bringing the stent from Czech Republic and implanted it in the United States, we didn't make it. The patient didn't make it. And the patient died on his bronchial stenosis without receiving the biodegradable stent. Next one, please. This one, next one. So you see, here, first contact, FDA approval, Dean's approval, but here all the improvements and all the allowances that they took too long. Next one. This patient, as I said, this was the European patient 1, was since the birth was connected with the ventilator. And we gave this family, before the child died, we did what we could. And we gave them 2 months where they could take the child home, outside of the hospital, and be at least a little bit parents. Next one. So they could have the child like that. This is the daughter. And they could take her home, and they are thankful that we gave them a hope. Next one. This patient was, after 6 months of normal response to ventilation, was connected with ventilator, and we gave them 1 month with the biodegradable stent. We gave them 1 month of normal life. So they were able to leave the intensive care unit and go for a walk outside. Next one. And the boy could even smile. Next one. So what were actually the indications for this? What were why they needed this stent? This was the first patient, complex cardiac. Next one. So if you see, this patient had only 1 vessel arising from the heart. Then this was divided then on the aorta and pulmonary artery, so needed a complex cardiac reconstruction with a homograft, with a tube which connects the right ventricle with the pulmonary artery. Next one. And developed after this surgery stenosis, or the external compression of the left main bronchus. Next one. So this is the cut through the patient. You see the 2 bronchi, and you see the ascending aorta and descending aorta, and you see the pulmonary artery with pulmonary bifurcation. It's a so-called crowded mediastinum, where the vascular structures pushes together the airways. Next one. And you see narrow, next one. Almost no bronchus, next one please. Next one. This was the 3D reconstruction, next one please. And here you see the narrowing. So this narrowing caused complete dependence on the ventilator, next one. And this is a bronchoscopy. This is the trachea, this is the orifice of right bronchus, which is open. And here, the left bronchus doesn't open. Here. You see it's closed. Next one, please. Next one. And this is the result where we put the smallest, I think to date, the smallest biodegradable airway stent into the left bronchus, which holds the bronchus open. Next one. And this is the timeline. Week 1 or week 0. Here, the stent was implanted. Week 2, patient disconnected from ventilator, could be discharged from ICU. Next one, please. But gap of 6 weeks. 6 weeks, we didn't check the patient regularly. And this was the 6 weeks which are critical. And you see what evolved, what it was to expect. We did not expect that it will not evolve. But it evolved a granulation on in the left bronchus. Next one. So this was bronchoscopy from here. And here, there were no bronchoscopies. The patient was not examined. Next one. As a preliminary solution, because the proper size of the stent was not available, there was inserted a stent in the trachea with the hope that this stent could hold even the bronchus, because the external compression was so high. Next one. But unfortunately, 1 week afterwards, you can see that's the trachea, that's the right bronchus, and that's the left bronchus. Next one. And next one. Here is the original bronchial stent, and you can see that behind it there was an accumulation of putrid secretion, which was not properly removed by bronchoscopies. And actually the patient died on a generalized pneumonia and sepsis. Next one. So this was then the histological examination of these granulations. Next one. And one more. So, if you remember now, next one please. This tracheal tissue damage score, where the maximum reaction to the biodegradable stent is in this time. Next one. You can see that during this time, where the clinical situation should have been expected to worsen, we didn't take proper care of this child. Next one. And this is the second patient. Next, please. Has also complicated, was born very small, and next one. Had this diagnosis, where this is the pulmonary artery, right pulmonary artery, and the left pulmonary artery doesn't go here, but goes around trachea and causes actually tracheomalacia in the distal part of trachea. Next one, please. So this patient was operated at least 3 times with tracheal resection end-to-end anastomosis, with the replacement of part of the trachea with cartilage which was taken from his ribs. Next one. And the mother contacted us in this situation. This is trachea, and there is no trachea anymore. Next one. Next one. So you can see that the distal part of trachea was actually dissolving. Next one. This was old-fashioned bronchography, which is really useful. Next one. You can see here. This is the side or the side view. Next one. And this is then the bronchoscopy. This is the anterior part of the trachea. And you can see there is almost no lumen. This patch, this flap of cartilage doesn't hold and closes the trachea completely. So that's why was the patient ventilator dependent. Next one. So it was here. Week 0. Next one, please. So we were able, with Ella, to put this stent, and you see a tremendous change in this patient where the trachea was actually not existing, not holding. Suddenly, the airways are free, and the patient, next one, and the patient could be disconnected from the ventilator. Very nice. So, but now we have 9 weeks. Next one, please. And after 9 weeks, which was done with the view that after 9 weeks we lose the radial forces of the stent, a second stent was implanted in the same place. But it was implanted not perfectly. This is the orifice of left bronchus. There is the orifice of right bronchus. And next one, please. So it was here. So the first generation of the stent was 9 weeks old, and the patient had a new generation, new stent. Next one, please. Unfortunately, the stent disappeared again, and the patient changed his doctors. Next one. Next, please. So we were now here. The first stent was 20 weeks old, and the second stent was 11 weeks old. And the patient needed to be intubated again and connected with ventilator. Next one. These are the markers. And this patient had, in this moment, just 2 markers. It means the 2 markers from the first generation were actually had disappeared. He coughed them out. Next one. And this was the CT scan, which showed, you see the remaining 2 markers and the stenotic part of the trachea. Next one. So in this case, the stent was used as a bridge to decision. If the decision was okay or not, it's to be asked, because this patient had a removal of this small piece of stenotic trachea. This is the piece of stenotic trachea, surgically. Next one. And this is the histology. You can see the piece of trachea, the cartilages. And have a look on these islands. These islands are the transection of the stent, where the first generation, 20 weeks old, and the second generation, 9 weeks old. Next one. So you can see that actually this stent, the first generation stent, really dissolves, changes, rebuilds, but produces no inflammation, produces no encapsulation, and on its own does not produce any hypergranulation. And this is the stent with 11 weeks old, which was cutted through. Next one. So here one more time, the beginning, when both stents were implanted, you see the overlapping, that the golden markers were still there. And next one. And because the patient after this resection still did not recover, and the therapy was more aggressive. Next one. He received another resection of the distal trachea, and he did not recover from this resection and spent 3 weeks on ECMO, which is extracorporeal membrane oxygenation. And afterwards, the family decided to stop the therapy. Next one. So, what was here the mistake? Why was the hypergranulation? Why appeared the stenosis? And let's hear this part of the stent. See, the stent did not opened completely. The stent was a little bit too deep and was covering the orifice of left bronchus. And because the patient did not have regular bronchographies or bronchoscopies to remove any secretions, here just behind the stent accumulated this purulent secretion and slowly rebuilt in a hypergranulation. So it was not perfectly positioned. The stent was not perfectly positioned because in comparison with the first stent, where the stent was more cranial, there was no overlapping and no mechanical burden. Next one. So I can see and I can draw a conclusion from this experience that the stent, biodegradable stenting is safe and sustainable, as Martin presented from Great Ormond Street Hospital, but only if the patients are treated in one institution, because these patients are so complex. They have cardiac, they have thoracic, they have tracheal diseases, so they need to be treated by a multidisciplinary team. And unfortunately, it was not the case of these two patients. They were treated in 6 different hospitals with about 10 physicians making decisions independently. So it is not such a good message for Ella, that it is not so good to sell the stents everywhere, but on the other hand, without this trying, without this first cases, we wouldn't know that. And we can just support this, and we can just organize ourselves, maybe like more multicentric, to focus and to concentrate these patients in few hospitals. The London hospital is a little too expensive for European patients, but probably, or we really should try to find a continental hospital where we can concentrate these patients to give all knowledge and this really close follow-up to prevent any other fatalities. So that's my conclusion. Thank you.